Hi, this is Tim Henry from Cedars-Sinai in Los Angeles at the American Heart Association sessions in New Orleans. And I'm here tonight to talk briefly about a fascinating session, cell therapy, is it ready for prime time? And I was the moderator with Stephanie Dimmler from Frankfurt, Germany, and Joe Wu from Stanford. And we had four late-breaking clinical trials, as well as a highlight of where cell regenerative medicine field is from Andre Terzic at Mayo Clinic. So I'll give you a brief update of those trials and where I think that they will play a role in sort of the regenerative medicine field. The first was presented by Mike Murphy from Indiana. And this is a very important trial. This was patients with critical ischemia. It included both Rutherford 4 and Rutherford 5 patients. And this is an important factor. It was a double-blind placebo-controlled trial that used autologous bone marrow mononuclear cells. And it's important, and it will come back to this, but 3 of the trials today used autologous cells, where the fourth actually compared allogeneic, which come from a young healthy donor, to autologous. It's an important concept because we know as we get older, the number of our stem cells and the potency of them decline. So when you use autologous cells, that there is potentially variability in the cell product that's given. So this is a very high-risk patient population. The primary endpoint was the combination of or amputation-free survival, so looking at both amputation and mortality. And what the trial showed is that overall, there was a strong trend that did not quite meet statistically significant. And the endpoint were roughly 30% events in the placebo arm and 20% in the cell-treated arm. But in particular, and these were pre-specified stratifications, if you looked at patients who were Rutherford 4, so less severe illness, and those patients who were not diabetics, there was a very strong, significant reduction in amputation-free survival. So I think this is a very important trial. It's a little underpowered in terms of a little small, but very large for a critical ischemia trial. And I think this really should focus and say, this is a group of patients that really have no options and that very high rates of amputation. So in the placebo group, 30% event rate. So I think this should stimulate further investigation in this field. And clearly we don't know yet which is the best cell, should you do repeat dosing, but clearly this shows that there's evidence for support. The second trial is also with peripheral arterial disease and is a very important trial. It was presented by Emerson Perrin at the Texas Heart Institute, and it was sponsored by the NIH, the CCTRN, or the Cardiovascular Cell Therapy Network. And this is also a double-blind placebo-controlled trial for patients with claudication. The reason why I think this trial is most important is, number one, it represents the largest randomized placebo-controlled trial in claudication with cell therapy. But second, there was extensive MRI endpoints used. So I think as important as the cell therapy were the use of novel endpoints that were in particular to get insights into the development of blood flow or the mechanism of action. So I think very important for that reason. The trial, again, relatively underpowered, but did show benefits, trends for benefit in terms of peak walking time, claudication onset time, collateral cell growth by MRI, time to peak flow by MRI, and some quality of life. So really trends in the right direction. Did not reach statistically significant except in some specific subgroups. But I think, and the cell used was ALD bright cells. So it's an autologous cell and an endothelial progenitor-like cell with the goal that you would improve both either arteriogenesis or angiogenesis. So certainly I think some suggestions, some very positive benefits that the use of cell therapy for patients with claudication has a future. So for those two trials, I think, really pushed the field of cell therapy or regenerative medicine for peripheral arterial disease. Both trials relatively underpowered, and I think what we need to do now is to use the results of these two trials to design larger trials and really think hard about the ideal cell and the ideal time point. The third trial is actually another trial sponsored by the CCTRN and the NIH, and is a 2-year follow-up called the TIME trial. And the TIME trial randomized patients to autologous bone marrow mononuclear cells versus placebo. The trial was published several years ago. The 6-month results showed no difference in between bone marrow and placebo. These are the 2-year results, and presented by Dr. Jay Travers from the Minneapolis Heart Institute at Abbott Northwestern in Minneapolis. And I think a couple important points about this trial. Overall, it showed at 2 years there was no differences in terms of the MRI. But I think it's important to note that only 87 patients had 2-year follow-up MRI out of 120. So it was a dropout of about 25 to 30%. And this is important because I think we think of MRI as the gold standard, but when you follow these myocardial infarction patients over time, you end up losing quite a few. And I think there's a couple important points. Number one, even though these were high-risk anterior infarcts, 120 patients, at 2 years, there was only 1 cardiovascular death. So cardiovascular mortality of 0.5%, even though these are high-risk patients. It tells us that we've changed the natural history of this disease. The second important point was there was a fair number of patients, though, that did get ICDs. And if you look at the missing patients, there was a significantly worse ejection fraction in those patients than in the overall group. So it shows out the challenges of doing these trials over time. The changing natural history of the disease, number one. And then number two, what's the ideal endpoint? So the fourth trial was a very important trial in a very large patient population, and that is non-ischemic cardiomyopathy. And this was presented by Josh Hare from the University of Miami. The trial is relatively small, and that was only 37 patients, but it was randomized to allogeneic mesenchymal stem cells versus autologous mesenchymal stem cells. Now, first of all, the patient population. About half of the patients with heart failure have a non-ischemic etiology. And heart failure is really the largest burden of disease from cardiovascular disease in the United States. So this is a huge unmet need. And these patients who have class 2 to 3 heart failure and who, despite medical management and despite device therapy, really have limited options besides heart transplant and left ventricular assist device. So if we could have a therapy that actually could reverse the process or even prevent progression, that would have a major impact on cardiovascular health in the United States. So this trial was really an idea to look at allogeneic and versus autologous. And it's a complex trial. There was no placebo group, but I think it's safe to say that what the trial showed was that the allogeneic cells were well tolerated. There were some immunologic responses, but they were mild and not clinically significant. So it shows that allogeneic cells can be given safely. And second of all, if you look at the preponderance of the endpoints and evidence, it shows that really allogeneic cells would appear to have some advantages over autologous cells. So I think overall it was a fascinating session. I think it really has important implications for the field of regenerative medicine and moving us forward to the next thing. But I'll point out for everyone out there, this is a challenging field for sure, because number one, there's changing natural history of disease, and it's challenging from a standpoint to get adequately powered trials. But I think we need to be patient, because I think this is true in every field that we did. Our initial heart failure trials, our initial reperfusion injury trials, all take time to determine mechanisms and determine the right approach. But I think the evidence today, really presented from 4 very diverse trials, show that we're making progress. So thank you very much from the American Heart Association in 2016.